Hello everyone. In this video, we will discuss about drug synergism and antagonism. First, let us start with synergism. So, what happens in synergism is that action of one drug is facilitated by the other. If we are giving two drugs together, action of one drug is facilitated or enhanced by the other. The other drug, the second drug, will enhance the action of the first drug. That is called synergism. Now, synergism can be of two types, additive or supraadditive. In additive, what happens is if two drugs, let's say A and B, are given together, their effect will just simply add up. So, the total will be equal to the effect of drug A plus the effect of drug B. Both of them will just simply add up and give a combined effect, and that is called additive. Okay, that is why the add word is there. Additive, they'll just simply add up, but their side effects do not add up. Even though their effects add up, their side effects do not add up. So in the long run, giving this combination is better tolerated by the patient. Whereas if we look at supra-additive, what happens here is supra, which means given together, drug A and B given together, their effect will be more than the effect of A and the effect of B individually. Their effect will be more. Why is that? Is because one of these drugs will act in a way that potentiates or enhances the action of the first drug even more. Let's say drug B will act in a way that will potentiate the action of drug A even more. So that is why we get a supraadditive effect. Supraadditive is when effect of drug A and B is much more than the effect of A and effect of B. And additive is when they just simply add up and these effects of A and B are equal to the effect of A and effect of B. Let's look at a few examples. In additive, you have aspirin plus paracetamol. So as analgesics or antipyretics, their individual effects are just add up and they give an additive effect. Same with nitric oxide and halothane as anesthetics. And amlodipine and atenolol will act as hypertensives. Glibenclamide and metformin for hypoglycemics, and ephedrine and theophylline as bronchodilators. So all of their effects will just simply add up and give a combined effect. Whereas if we see supraadditive drugs, acetylcholine and physostigmine, when they are given together, since physostigmine is an acetylcholine esterase inhibitor, it will inhibit the breakdown of acetylcholine and potentiate its action even more. Same with carbidopa, it will inhibit the metabolism of levodopa and potentiate its action, bringing about an even greater action as compared to individually. Next, we have cocaine and adrenaline. Cocaine will inhibit the reuptake of adrenaline and potentiate its action. Sulfamethoxazole and trimethoprim act by sequential blockade. Now let us look at antagonism. What will happen in antagonism? One drug will decrease or abolish the action of the other drug. So let's say there is a drug B. If it is given along with drug A, which means, look over here, if drug A and B are given together, it will inhibit or abolish the action of drug A, and the resultant effect will be less than the drug A plus drug B if they were given separately. So one drug will decrease or abolish the action of the other drug. If we look at the types of antagonism here, the first one is physical. Physical antagonism is based on physical properties. For example, if there's a case of any alkaloid poisoning, if there is somebody who has ingested alkaloids, charcoal is given. What charcoal does is that it adsorbs the alkaloid onto itself. So on top of the charcoal, the alkaloid will get adsorbed, and because of that there will be less alkaloid available in the stomach or in the gastrointestinal tract for absorption into the body. So that is how it will inhibit the toxicity or the toxic effect of that alkaloid by causing adsorption, and this is a physical property. So this is an example of physical antagonism. If we look at chemical antagonism, there will be two drugs and they will react chemically. Drug A and B, they will have some sort of a chemical reaction, and at the end of that reaction, they will form a product which is inactive. So, at the end of the day, it will not have any effect in the body at all. Let's say again with alkaloids, if there is some sort of an alkaloid poisoning, potassium permanganate or tannins, they will react with these alkaloids and the resultant product will be inactive, so that the alkaloids will have no toxic effect on the body in the long run. Same with chelating agents like EDTA or BAL. We use them in case of heavy metal poisonings like lead or arsenic. They will also react with the lead and arsenic in such a way that they form a product which is inactive, and they will not let arsenic or lead cause the toxic effects in the body. Same with nitrites and methemoglobin. So nitrites and methemoglobin combined will form an inactive product, and so the toxicity of methemoglobin will reduce. Next, we have physiological antagonism. In physiological, there is a physiological function in the body. So let's say bronchoconstriction. Okay, let's say there's bronchoconstriction. One drug will potentiate it, or one drug will cause this physiological action. The other drug will inhibit this physiological action. So again, if we talk about this bronchoconstriction, histamine will increase bronchoconstriction. If histamine is given, it will increase bronchoconstriction, whereas adrenaline will decrease bronchoconstriction. So the way physiological antagonism works is that there are two drugs. One drug will act by potentiating or increasing this physiological function. The other will act by inhibiting this physiological function. In the examples, we have histamine and adrenaline from bronchoconstriction, as I mentioned. Then for potassium excretion, we have hydrochlorothiazide and amiloride. Hydrochlorothiazide will cause potassium excretion from the body. Amiloride will not, because it's a potassium sparing diuretic, so it will not cause potassium excretion. So that is how they become physiological function. Both of these drugs will have an opposite action on one particular physiological function over here. Next, with glucagon and insulin. Glucagon, the physiological action is blood sugar, and glucagon will increase blood sugar. Insulin will decrease blood sugar. So this is how physiological antagonism works. Both of these drugs will have an opposite action on one particular physiological function. If we compare it with receptor antagonism, they are different. So receptor antagonism, drug A and drug B, these two drugs will have an opposite effect on the same receptor. In physiological, these two drugs have an opposite effect on one particular physiological function. Let's say bronchoconstriction. They have an opposite effect on one function. But in receptor antagonism, both of them will have opposite functions on the same receptor. What it means is that, see, one receptor will have multiple functions. Let's say it will affect bronchoconstriction, it might affect blood pressure, it might affect capillary tone, it might affect your glucose metabolism. Drug A and drug B in receptor antagonism will have an effect on all of these physiological actions. In physiological antagonism, both the drugs had an effect on only one physiological function. In receptor antagonism, these drugs, these antagonistic drugs, will have an effect on all of the actions that this receptor mediates. Receptor antagonism can be of two types, competitive or non-competitive. Let us look at competitive antagonism first. Competitive is an equilibrium type of antagonism. So what happens here is that the antagonist and the agonist are chemically similar. So they are both similar compounds and they will bind to the same receptor. A and B, they will both bind to the same receptor. They will both compete for the same receptor. They want to bind to the same receptor. Okay. And because of this binding, if the antagonist ends up binding to the receptor, it will produce no response. And the action of A is also inhibited. So at the end of the day, it will produce no response at all. If we look at the dose response curve, the DRC shifts to right in this case. So if this was the dose response curve with only A, the DRC will shift to right if both A and B are combined. This will mean that a higher dose of the drug A will be required to produce the effect that we are desiring. Okay, so what B has done is that it has binded to the receptor that A wanted to bind to, and it has produced a zero effect, a no response. Okay, now if we want that same response again, if we want A's response again, we can do that if the dose of A is increased. If a lot of drug A is given, if drug A is given in excess, this antagonism can be reversed. But the shift to right will mean that a higher dose of A will be required to produce the same effect as that would have been produced if B was not there. This is competitive antagonism. In non-competitive antagonism, it is a non-equilibrium type of antagonism, and they are not chemically similar. The drug A and drug B are not going to be chemically similar, and they will also bind to different sites on. So there are different receptors. B will bind to something called an allosteric site. A will bind to its normal site. B will bind to an allosteric site, and it produces some changes in the conformation. In this, the antagonist again produces no effect, and the log dose response curve is flattened. That is, its height gets decreased. In competitive, we had a shift to the right, but in non-competitive, the dose response curve flattens. And in this kind of antagonism, it is not reversed even if drug A is maximally increased, because B has not bound to a site that A was going to bind to. There's no competition here. B has bound to a different allosteric site, completely different site. So even if A is increased, it's going to be of no point, because if B is already bound to it, bound to the enzyme or the compound, it will not allow it to produce the effects that were going to be there by drug A binding. So even if A is increased a lot, the action is not going to be reversed, or the competition is not going to be